Okay, so thank you for joining us. So we're both physicists and we're going to take you through the key piece of legislation that protects patients from radiation. So we're going to talk about why we control ionising radiation, what the risks are. We're going to go through the main international principles of radiation protection. Then we'll go through the basics of IRMA and the basics of protecting yourself. And then we'll do a little bit of our culture. So when you're working in the hospital, you may have seen some rooms that have signs such as the one on the slide. They may say something like X-ray controlled area, no unauthorised entry. And the reason for that is because ionising radiation is associated with certain risks. They're mainly divided into two separate types of risks: tissue or deterministic effects and stochastic or random effects. Now, the deterministic effects or tissue effects, they have a threshold dose below which you won't see that effect, and above which the severity of the effect increases with dose. So they are things like skin erythema, hair loss, sterility, that sort of thing. We don't ever expect to see those effects in members of staff, but you may see them in patients, for example, in interventional radiology, if it's a long, complex procedure, or if the patient is quite large, you can see skin erythema. So it's important that the patient is aware of that beforehand if it is a potential risk. You can also see effects on the fetus of any pregnant individuals, but the threshold for that is quite high. It's around 100 milligray, and it's things like reduction in IQ, of the actual fetus, and the thresholds depend and the effects depend on the point in the pregnancy at which they were exposed. Then the other type of effect are stochastic or random effects. So they have no threshold dose. So we believe that there's no safe dose of ionising radiation. As you increase the dose, you increase the probability of seeing one of those effects. So those effects are things like leukemia and cancer induction, and induction of hereditary defects in the offspring of the exposed individual. So that's things like one eye being a different colour to the other. And although we've proved that hereditary defects do occur in animal models, we've not been able to definitively prove that they occur in humans. So the risk is very small for that. In the middle, we have cataracts and glaucoma. So originally they were thought to be tissue effects with a threshold dose, and now they're thought they may be quasi-stochastic, so they may not have a threshold dose. So as we progress in our understanding of how radiation interacts with the body, things do change. So because of the fact that radiation has an effect on the body, and when I'm talking about ionising radiation, I'm talking about things like CT, X-ray, fluoroscopy, and nuclear medicine. MRI does not use ionising radiation, so the risks that we're talking about here are not to do with MRI. So because we know that there are risks associated with it, there are three main principles that we use to protect from radiation. The first is justification. So we should never use radiation unless the benefits outweigh the risks, and that can be to the individual themselves or society at large. The risks can depend on age, sex, and the scan. So when you're justifying the exposure, you have to take that into account. And the benefits obviously depend on the actual presentation of the patient and their patient pathway. So for where we may expect larger benefits, we may accept also larger risks associated with the exposure. The next principle is optimization, and that's that if we say that we need that X-ray or that CT, we need to keep the dose as low as reasonably practicable, consistent with the intended use. So we want to, if we have to do a chest X-ray, we want to do a chest X-ray with the smallest dose possible while still having a usable chest X-ray. And then finally, we have limitations. This is mainly where there's no benefits to the individual. So for example, staff and the public are given dose limits which should never be exceeded. And that's why I said at the beginning, staff, you should never see erythema, because it's the dose limits are set so that they are so much lower than the threshold for that actual effect. So those three principles are the core principles of radiation safety, and they're the foundation on which IRMA is based. Now, IRMA, or the Ionising Radiation Medical Exposures Regulations, which is a bit of a mouthful, so I'll say IRMA from now on, are set down to protect the patient. There is another piece of legislation which is called the Ionising Radiation Regulations, which concentrates on how we protect the staff and the public, so those who don't directly benefit from the exposure. And we're going to concentrate mainly on IRMA for this presentation, but at the end I couldn't resist putting in a little bit of safety for you guys as well.
Just going to talk about within legislation, it identifies individuals who are part of the exposure, about the process of taking exposure and referral. So, going through the duty holders, we've got the employer. So the employer needs to provide a framework for how medical exposures occur within the organisation. They need to provide us with procedures and protocols on how we do that, and to ensure that there's assurance that the quality of what we're producing is sufficient. And they also have to entitle the other duty holders within from the legislation. So the referrer is the person who must be a registered healthcare professional, and they have to be entitled to request that an individual requires an exposure to radiation as part of their clinical care. And that's generally a doctor, maybe an outpatient doctor, or it might be a GP. But we also get non-medical referrers. So we can have nurses and physiotherapists. Anybody who's registered can be referrer, but there's sometimes a difference in the training that's required. The practitioner, their role is to justify the exposure, and justification needs to be ensuring that there's a benefit, and it has to be weighed up against the risk from that person receiving that exposure. And that's generally a radiologist, but there can be radiographers who work within that role. The operator, the next one, so they're involved in the practical aspects of the exposure, and they're generally looking at optimizing the exposure, and they also do authorization, where they authorize exposure and check identity, pregnancy status, things like that. And also, if you are evaluating an image, you're also classed as an operator. So we put down a radiographer there, but if we're sort of saying in potentially in interventional radiology, you may have a radiologist who acts in as referrer, practitioner and operator. It very much can be sort of a mix of the roles, dependent on how it works. And it's very much dependent on your local procedures within your organisation. And the last duty holder is the medical visit expert. And medical experts have the knowledge and experience to assist with helping with compliance with legislation, looking at optimization, and all the other sort of physics-based aspects of the radiation exposure. Okay, so just going to touch on the training side of things. This comes from the fact that there's quite a lot of there's emphasis within legislation about this, and they actually provide a curriculum for both operators and practitioners. And it's quite specific in what's required. So they provide both generic and speciality curricula, and the sort of generic sort of topics sort of look at that sort of basic understanding of what radiation is and how it sort of interacts. Then sort of looks at the risk aspects of it. So the operator practitioner need to understand about the hazard and that side of things, and also about radiation dose. And how that relates to that sort of risk and that side of things. How you sort of manage and protect the individual being exposed, so that optimization side of things, and other sort of areas like with special interests, it looks at sort of you need to understand about pregnant patients, in what aspect, in what situations can they be exposed, not exposed, and sort of linking it to very much with justification and the aspects around that. And then the last bit, it sort of touches on something which is it's a bit with the ionising radiation regulations, the stat side of things, is about radiation protection of the patient and yourselves, really. Then with this sort of speciality stuff, it's very much dependent on the area that you're working in, and very much your basic training within the area will cover all these sort of aspects within the requirements of legislation. Also, it is very specific in what it requires, things like all the records and the quality assurance side of things. So it needs all the dates to be there, it needs to have what the training and nature of the training is, all that side of it all needs to be there and present if the organisation is ever inspected, to make certain that anybody doing exposures or any person involved in the process of exposing a patient is appropriately trained. Another bit of the training is that, as we've spoken about, we have procedures. So procedures are within the employer creates, and that is another part of the training that you need to go through those and to be fully aware of how that works. And if you are a duty holder, you have a legal responsibility to follow those procedures. Okay, so I'm going to move on to the patient pathway. So the patient journey from what the process is before having a medical exposure and then afterwards. So starting off with the referrer, and if the patient requires imaging, the referrer has to sort of look at what they are asking for, what is the clinical question they need to be answered. And within that referral, they need to make certain that there's appropriate and adequate clinical history, so that the examination can be justified. Quite a nice resource is iRefer, which is online. I think most of the NHS can get access to it. And when you're putting what the clinical question you're asking for into it, you can sort of see the different modalities that may be useful for looking at that clinical question, and the risks and benefits with them, which is quite a nice resource. Also, it's sort of specify, the referrer might have to specify specifically for if there's non-medical reason, non-medical imaging reason for it, such as a migration, chest exposure to look at TB. And also the referrer might need to sort of comment about is the patient pregnant or not within that. When the referrer has done that, the referral then goes over to the practitioner, and the practitioner carries out that justification, weighs up the risk and benefit, and if there's a net benefit, approves it. It's not always the practitioner doesn't always justify every exposure. If there is a common examination with common clinical questions, the departments write what we call authorization guidelines, and these written protocols specify that these exposures are justified for these particular reasons, and that means that the operator can authorize it under these guidelines, and so you can sort of streamline the process for very common examinations. And then when that's done, it's then passed on to the operator, who's carrying the practical aspect. They need to sort of check, is the equipment safe to use? Has the equipment been quality control tested? Is it working appropriately? Yes, is the operator trained? And there's other sort of aspects of that sort of exposure, sort of thinking about, is it a research exposure? And as it's come from the practitioner or from the correct route, that is justified and authorised. And when they do the exposure, they need to be thinking about the protocol that they've selected for it. They need to think about optimising the exposure. So is it appropriately collimated? Is the patient correctly centred within the image? And when they've taken the exposure, they need to think about recording the exposure parameters, the dose that's been delivered, and then comparing them to the diagnostic reference levels, which we'll touch on later. And then and a sort of final bit is all exposures must be reported in a timely fashion. Really, if we aren't reporting the exposure, then the exposure hasn't then hasn't been really a reason for the exposure, and in essence that is an incident. So making certain that clinical evaluations occur for all exposures is very important. Now, throughout this process, incidents can occur where patients can get unintended exposures or accidental exposures. And if an incident occurs, need to make certain that the situation is safe. We need to make certain that the incident is reported and that the appropriate people are informed of the incident. So the patient, the referrer, the practitioner all need to be informed. And they also need to be informed of the outcome of when you investigate it. And the really important bits around learning from the mistakes and sharing that learning. So one of the sort of things that was being brought in by the Society of Radiographers was around patients, around reducing risks and improving that sort of process. And reducing the number of incidents. And this meant that they came up with this idea of pause and check. So it's a checklist of sort of the key safety questions that the operator, or in this case, the referrer, needs to think about before they are sending off the referral or actually carrying out the exposure. And it's sort of quite a sort of important sort of thing to sort of highlight, to make certain that people are know what they need to be looking at and making certain that the process is being followed. But this doesn't really take away from the fact that you still need to read the error procedures and understand how locally systems work.
So one of the biggest incidents that we tend to get is incorrect patient referrals, and they're really difficult to actually catch at a later stage. So if you are referring on a referral system and you select the incorrect patient, but you type in the correct clinical history, unless that clinical history visibly doesn't match the patient that arrived, it's very difficult for it to be picked up before it goes through to imaging. And if it's above a certain level of exposure, then we have to report it to the CQC and do a full investigation. One of the other requirements of IRMA, which is a new requirement in 2017, is that we have to provide, wherever practicable, adequate information to the patient before the exposure about the benefits and the risks associated with it. Now, this is quite a challenging thing to do. I don't expect everyone to know the risk levels associated with every exam, particularly because there's quite a wide range and it depends on the age and the sex of the individual. It's not as straightforward as a single number that we can give you that you can communicate to the patient. So what I always advise, but you have to look at your local IRMA procedure, is a graded approach to informing patients of the risks. So for plain film x-rays, where the majority are really quite low risk compared to the natural risk of cancer, which is 1 in 2, the risk is 1 in 10,000, and that's the highest plain film risk. Most of them are more like 1 in a million. You know, that's the range. So I would say the referrer should introduce the risk and maybe provide leaflets around the risk, or posters, which I'll show you later. And then the radiographer should check that the patient's happy to proceed, but it should be informed implied consent rather than detailed written consent. For CT and diagnostic nuclear medicine studies, there's a slightly higher risk, and the patient through flow doesn't require consent already. So I would say that at that point we move to documented verbal consent. So just documenting that the patient is happy to proceed. And then for interventional radiology and cardiology, the risks are higher, but the patient is also usually having informed written consent anyway. So the radiation risk should form part of that consent process, and it should include any potential tissue effect. So if you find that when you go into interventional radiology or cardiology that the consent form doesn't contain those things, Every hospital will have a medical physics expert like us and should be able to provide that information so that you can add it to the consent form. Because it's a relatively new requirement, there are some places that are still playing catch up with what needs to be done. So to try and make it easier for you guys, the best way I think to introduce the risk to the patient, and we've done a lot of work around looking at what patients actually require from us, is, I would say, introduce that you're going to refer them for an x-ray or whatever, and that we believe that the test may be linked with a small increase in the risk of cancer later in life, but that risk is much smaller than the natural risk of cancer, and without it you would not be able to diagnose whatever condition you think, or determine the best method of treating them. It's also really key that you emphasise that an imaging specialist will check that request before it goes ahead and only allow it to proceed if the benefits to you are greater than the risk. So we did a really large survey of members of the public, and we found that key sentence actually was what made most people happy to continue. Some people will want more detail, and if they do, there is a UKHSA leaflet which you can access. All the links are in the slides at the end as well, but it gives broad ranges of risks, and you can see they're very broad bands of risk categories. And there's also some posters available from the RCR which go in some detail about the levels of risk. The best source of information is the UKHSA. So we have to inform people of the risk, and we know that risk varies with age and sex. The younger you are, the more time there is to express that cancer risk. And in pregnancy, we see this risk increasing further because it's a time of rapid cell turnover. So the risk associated with exposures in pregnancy is greater than that for the rest of the general public. That's why the referrer should detail pregnancy status on the request form, but the radiographer will also check it at the point of exposure. One key point to this, which has recently come up from the professional groups, is that you cannot assume that patients that are male or present as male are not pregnant. And there have been a few incidents that have shown that this is more than just a theoretical risk. It is a real world risk. So provide as much information on pregnancy status as you can. On that slide, I've given you some examples of the higher dose exams, the additional risk of childhood cancer, and you can see for a CT of the pelvis and that sort of thing, exposures of the CTs of the area around the fetus, and you can get an approximate doubling of the natural childhood risk of cancer. So from 1 in 500 to approximately 1 in 1,000 to 1 in 200. So the next group that we need to be concerned about are people called comforters and carers. Now, this is a really specific term under the legislation, and it's individuals who are knowingly and willingly expose themselves to radiation in support of another individual. This is not a nurse who comes with the patient and helps to hold them in position. They're a member of staff that is covered by IRR and a separate piece of legislation. This is, say, a parent who comes and stands in the X-ray room by the child in order to keep them calm for the X-ray. Now, they will be exposed. They must understand the risks to them, and those risks must be justified. They shouldn't really be pregnant or children, but you can get the risks to these types of people justified by a practitioner. So most trusts will have an authorisation under protocol for carers and comforters that a radiologist has signed off on as the practitioner. And usually it'll say something like, if it's required in plain film, then as long as they haven't supported a patient X number of times in the past, they're not pregnant and they're not a child, it can go ahead. As I say, you can then go to a radiologist and get additional justification if it's outside of those constraints.
So within the legislation, a key aspect of it is quality assurance. And as with most organisations, quality assurance is a key part of how they work. And as you can see straight from the legislation, all those planned and systematic actions necessary to provide adequate assurance that the structure, system, component or procedure will perform satisfactorily. And that's the main principle of quality assurance. And I think that within the legislation, it very much picks out sort of 3 different areas that we need to think about regarding quality assurance. The written procedures, that employers' procedures that we've spoken about, and that very much is sort of reviewed using audits that are specifically looking at those procedures. We have equipment, which has to come under a quality assurance program. This is generally the testing of the equipment doing quality control testing. So this is looking at the sort of radiation exposures it delivers, the image quality of the equipment. Are both of those within the expected ranges that we expect, and are they delivering a sort of optimized images for clinical evaluation? And then we have protocols. So that is very much around looking at sort of optimization and diagnostic reference levels. Equipment very much comes in checking that the quality control testing is okay. Also comes under optimization, but we very much look at sort of protocols for that optimization side of things. And as you can see from the audit spiral, by continuing auditing, by sort of looking at a standard, reviewing it, and then implement, and then seeing if there's a problem, then implement change. You're sort of going through that audit cycle, and that very much sort of improves assurance and leads to improvements within the what's delivered. So optimization. So this is the as Lizzie mentioned earlier, optimization is very much about if you are having to do something, you have to make certain that you are delivering the intended purpose from the dose as low as reasonably practicable. So that LARP principle. And it is essential to optimize each radiation exposure of a patient. And a key aspect of that is understanding the clinical question or need and being asked. And as I said there, different clinical questions can necessitate different imaging requirements. And that's why we have the practitioner there to evaluate the clinical question and to decide what is the best practice to deliver the answer to that clinical question. With the operator and their aspect of and especially in interventional radiology, with fluoroscopy equipment, CT slightly different, we need to make certain that the optimization looks at that the practical aspects, that the operator is very much thinking about patient positioning. So as you can see from that diagram to the right, having the patient close to the imaging detector, so bringing the imaging detector close to the patient is important because that reduces the doses to the patient. We need to think about the correct protocol being selected. So is the frame rate low? Is the doses set to low? Or it depends on the situation what protocol is required. We need to think about collimated images wherever possible, because that also reduces the amount of scatter and also the direct dose to the patient. We need to think about only using magnified views where necessary. There's some equipment has particular settings to actually do a digital magnification and therefore no dose aspect to that. And use of specialist features within the equipment, so things like recursive filtering and last image hold can lead to improved image quality or no radiation dose for the same things like last image hold. A key thing to sort of think about with radiation protection within, especially arthroscopy, is that optimizing the patient dose reduces a dose that you will receive as the operator within there, and the impact on that. So it's always key to sort of optimize. Another aid to that optimization is very much sort of around the quality assurance side of things, and that is very much about how do we verify that we're not overexposing our patients. So we get a dose at the end of a procedure. How do we know that that's an acceptable dose? As you can see on there, all the doses that we deliver from each procedure are supposed to be recorded, and this allows for us to do dose audits and to analyse those doses. For the comparison side of things, we have the legislation introduces this concept of diagnostic reference levels. So these are dose levels for typical examinations based on samples of patients and equipment. And that allows us to have something to compare against, and between procedures. After the procedure, we compare the dose to the diagnostic reference level, or we can compare diagnostic reference levels to dose audits that we carry out. And I'm just going to show you an example of some of the results from a dose audit. So this is just from pelvis X-ray. X-rays that are carried out in the rooms that that is displayed on the bottom, and the dose is on the y-axis, and we've got two lines there. We've got a dotted line, which is the reference median dose, which is the diagnostic reference level that we previously had, and then we have the current median dose, which is the dose that's been delivered in the time period that's been looked at. So we can sort of see that between when the DRL was produced and now, that the doses have dropped on average across the equipment. So that's good. But at the same time, though, we've got a number of rooms where the doses are above, not just above the current median, but also above the previous DRL. And so this sort of indicates that, oh, what's going on there? We need to think about what we're doing. Does something need to change? And so if an area of concern is identified, we have to investigate it, and we investigate it by using a sort of multidisciplinary team approach, so called image optimization teams. And that's generally a radiographer, a radiologist, and a medical physics expert or clinical scientist. And very much we sort of review the sort of equipment side of things. Is the equipment the sort of the reason why they're higher? Is it the general practice within the room, or is it patient demographics? So we can sort of look at those different aspects and sort of determine, is there a particular reason for it, or do we need to do some optimization? Do we need to be changing the equipment settings? Do we need to be asking, looking at operators, and are they doing something which is not best practice, and can we encourage learning to improve that practice and reduce the overall doses? All this sort of aspect of sort of looking at medical exposures and optimization is very much covered by medical exposures committees, which you'll generally have at most large hospitals, and I would encourage you to get involved if you can. Another sort of area that's sort of picked up by legislation is looking at research and sort of biomedical research. And when we spoke about justification earlier, it was looking at the exposure is justified as being an individual, the net benefit to that individual being exposed. And that's what happens the majority of the time. But there are certain times when exposures occur which there isn't a net benefit to that patient. And how do we make certain that that exposure has sufficient ethical benefit? So when we have research exposures, we need to make certain that the research study has been designed correctly and that ethically the reason for the exposure is justified. And so the research will be reviewed by a research ethics committee, and there'll be a statement from a medical physics expert and a clinical radiation expert, which is generally a radiologist, and they will give the statement saying that it should be justified. But that's very much on a national scale. On a local level, the employer must have a procedure that looks at reviewing that original study and to see if locally we can meet the requirements, and also so that can we meet dose constraints, and if we are carrying out locally, are we how are we identifying patients who are undergoing research exposures, and how local authorization might occur, things like that. We sort of need to think about this sort of the process for research. And when things break down, such as not identifying a patient as a research, patient being exposed for research, incidents occur, and the legislation has specific requirements for incidents involving medical exposures. And the main reason for the sort of requirements within the legislation is to ensure that when this happens, that everybody's informed of it. So we're thinking about the referrer and practitioner to sort of aid and the operator to sort of inform learning, but also with patients to ensure that the individual exposed is being informed of what happened and what has been learned from it. And that's very much around a duty of candour, and to emphasise the sort of learning aspects of from the incident, really, and to improve practice. Another part of it in legislation is that if we have incidents which occur which go over certain thresholds, we have to inform the CQC, and that happens if the dose is much greater than intended, or which is when a patient might have an exposure that might be done on the wrong modality or things like that, or an accidental exposure where the patient shouldn't have received an exposure at all, i.e. around like misidentification of patients, that sort of side of things. And this sort of notification aids the CQC in looking at trends with incidents nationally, and they produce an annual report which includes this sort of these trends and sort of guides nationally how we can improve practice within departments.
So that was a whistle-stop tour, which I think is a really elegant piece of legislation, allowing us to have a framework for safely exposing patients to radiation. Now we're just going to talk a little bit about your safety. So if you enter a controlled area, so where those signs are on the door, it should be very obvious when you're entering a controlled area. And you must read and sign to say that you've read the local rules, and you must comply with those local rules. So this is if you're remaining, say, for example, within a CT room during exposure, you should have read the local rules and said that you'll comply with them. The radiographer within that domain is the individual who's looking after everyone's safety. They've had additional training in safety around radiation, and they're trying to help everyone to work safely. So if they ask you to do something, usually it isn't because they're just trying to show their power or anything like that. It's to make sure that you're working safely. If you work with radiation and you enter a controlled area, you'll be subject to a risk assessment, which will say whether you need to be monitored for your personal dose of radiation. If you are issued with the dosimeter, you need to wear it, and you need to return it when you're told to return it. If you fail to do so, you can be held responsible, as well as the trust, if something goes wrong. So there was a doctor who was fined £10,000 personally because he didn't return his dosimetry, and when he did, they found that he had exceeded a dose limit. You also have a responsibility to do any training that's required by your trust and wear PPE as instructed. Here is the good, the bad, and the ugly of PPE wearing. So you can see in the first corner, the individual's wearing a lovely vest, crossed over to provide double protection at the top. Next to that, we have an individual who may be wearing slightly too small vest, and it's not quite closing. That closure is the way that we ensure that there's adequate protection. So you need to make sure that you can fully do up the vest. And you see underneath the armpit of this individual, there is a gap, and there are the breast tissue is very sensitive to radiation, but there's also increasing evidence that the cardiovascular system, particularly the heart, is radiosensitive as well at quite low doses. And so you need to make sure that that armpit is fitting quite snugly underneath. And particularly if you're standing side on to the actual source of scatter. Next, we have the skirts, the lead skirt. So in the bad, it's the same. You need to make sure all that Velcro is covered up. And also that there's no gaps down the side. And then finally, thyroid protection. Your thyroid is particularly radiosensitive. So if you're given a thyroid shield and asked to wear it, please wear it up tight, close to your neck, not like a necklace hanging down. And then there's the unforgivable, and it might sound stupid, but we see this all the time, where someone in a theatre is wearing a lead apron, so everybody stands behind that one person, and they're not going to be protected behind that person. So please ensure, if you see that happening, don't be one of those people. You either leave the room while they're screening if you can't put on a lead apron, or put on a lead apron, because it's for your safety. And then finally, protect your eyes. We don't want you getting cataract. And so more recently, lead glasses and lead visors, particularly for people who wear glasses already, have started to become more normal practice. This is because of the evidence about cataracts not having such a high threshold for being caused by radiation as originally they thought, and that was proved by several papers looking at radiologists and the incidence of cataracts within them. So if you're issued with them and asked to wear them, please wear them. Please make sure that you're looking after them, because they are quite expensive. And if you have a ceiling mounted screen, that should be placed as close to the operator as possible in order to give you the maximum protection. And next, this is a little bit more about the patient, but along the same vein, it used to be quite common practice for patients to be offered what we call contact shielding, so gonad shields or lead aprons when they were having x-rays. Now, with modern practice and modern equipment, actually the amount of scatter outside of the field is very small, and we can collimate down to the point where we're only really looking at the area that we want to see. So the most recent guidance says that in almost every case, contact shielding is not required, and that also includes pregnant patients. The operator will optimize the scan to reduce the dose as much as possible, but please, as a referrer, don't tell a patient that they will get given a lead apron or gonad shields, because then when they arrive in radiology and aren't given those things, they begin to question whether they should have been, and sometimes that puts doubt in their mind about the practice of the radiographers, even though they're following best practice at the moment. So one thing I want to finish on is the standard that we will walk past is the one that we accept. So if you see potentially more senior individuals not wearing lead glasses when they should, please feel that you can challenge them, because it's for their safety, and we should all be doing our best to ensure that we're all safe. So hopefully today you've learned the principles of justification, optimization and limitation, the lovely piece of legislation called IRMA and how it implements those requirements of the international community by defining roles and responsibilities, requirements around provision of information to patients, assessing the risk to pregnant patients, optimization of exposures and research, and then how we deal with incident. Hopefully you've also learnt the real basics of looking after yourself in the radiology environment, but please, when you go back to your areas, make sure that you know your local procedures and your local training to make sure that you are doing what's needed locally. And finally, the importance of radiation safety culture.